the actors. The first case we're going to do that you can huddle up on, and we have a slightly different set of questions, is providing peer support to the ED physician who didn't quite capture that information on that first x-ray. And now the word's getting back to him about the fact that the follow-up x-ray, much bigger, turns out to be cancer. And so he's kind of beating himself up about what happened, but also having to listen to perhaps some criticisms from some people about, maybe having missed that first x-ray. So this is the, providing emotional first aid to a colleague, who's had this sort of thing happen. And so as Bruce talked, so that's the scenario. We'll have the physician coming up shortly. But in the meantime, and this is, the setting is you're in a very quiet conference room, one-on-one, where you're going to be meeting to provide emotional first aid. A couple other very important issues. You know him. Not really, really well, but it's not like you're a stranger and you have to totally introduce yourself to him. The other part is this physician knows you're part of the organization's Candor Care for the Caregiver program. So they know about the program. They know there's this attempt that's being made to offer this kind of proactive emotional support. So that's kind of the background stuff. At your table, these are different kinds of questions. In some ways they're the same, but they're different, which is think about, who's going to be willing to volunteer to go up and do this, but also think about in this situation. And remember, the next one is going to be the nurse who made the medication error. So in both these scenarios, you want to think about who is the ideal person to provide that peer support. For example, most people would say it's probably not best that it's their manager or supervisor. Because of the hierarchy and that person may be involved in the investigation. So it's important to think about when you come up here, identifying which role the who's coming up. So often it's a colleague, it's somebody at the same sort of lateral level, manager supporting manager, frontline supporting frontline, who's trained in how to do this stuff. And you're going to want to think about how do you respond, think of the questions and answers that Bruce provided. What questions do you anticipate when you go, hey, we come in, see how you're doing? What questions are you going to ask? And then what kind of follow-up may you or may you not recommend after you've had a chance to connect with the folks here? So why don't you take about 5 to 10 minutes, think of these questions, and then again, Bruce will ask for volunteers to come up, and we'll have, the ED physician who will be up here who will need somebody to provide peer support for. Any questions on that fact piece? Okay. Why don't you take 5 to 10, talk at your table, huddle up, go through these questions, and then we'll have somebody come up.
time to think about how you're going to comfort your friend or your colleague. Ideally, we'd like a physician to do this. Is there a physician left in the room, I'm looking at you, that might be willing to volunteer? All right, let's give her a big round of applause. That was a very direct, you were voluntold, I'm sorry.
So set up the scenario.
Yeah,
again, so they know they kind of know each other.
Exactly right. Can you hit B on the keyboard again to black out the slides in the background? Thank you very much. So just to review the facts, this is the physician, the ED physician who 3 months ago sent the patient home on antibiotics, basically diagnosing pneumonia. And then there was a screw up with the follow-up and the x-rays and so on and so forth. And now 3 months later, the same patient's come back in and looks like they've got cancer. So this is, let's say it's like just a couple of days after the patient has visited again and this has all come to light.
Do we actually know, the paper said that the x-ray was red as there was a nodule. So did we actually miss the nodule or?
He missed it and did not see the report that happened long after his shift.
Right.
In the ED. So he never saw the report because it wasn't out yet.
Right.
And he didn't see the nodule initially.
Exactly.
Yep.
Okay, so you're clear on the facts? And who will you be portraying? In real life, what is your role? Could you hold the mic?
I'm an OBGYN.
In real life, you're an OBGYN. Okay. And what kind of doc will you be portraying in this interaction?
I think emergency room.
Okay, another emergency room doctor. And you can assume that you are acquainted with one another as colleagues, but not close friends, okay?
So my name's Kevin.
And your name is Kevin. Yep. Whenever you're ready, please begin.
Hey, Kevin. How are you?
I've definitely felt better.
Yeah. I just saw you sitting here, thought I'd stop in and heard about what's going on. Wondered if you just wanted to chat, see how you're dealing with everything.
Yeah, thanks.
You been sleeping?
Not as much as usual, that's for sure.
Yeah. What's keeping you up?
I don't know, this whole thing is just, I don't know, I just feel like a lot of pressure, you know?
Yeah. Yeah. You're a great doc. I've seen you practice for a long time.
I appreciate that, but it doesn't feel like it right now.
Yeah. It's hard not to lose your confidence when something like this happens. Have you been working still? How long have you been dealing with this?
Just the last few days. Yeah, I've been working. It's difficult to, get out of your head, and focus. Yeah. I'm just trying my best.
Yeah.
That's what I think it feels kind of frustrating, because I'm just, I turn up here and I just try my best, and I feel like it's very frustrating when you screw up like that.
Yeah. It hurts to give everything you've got and then have it not go right.
It feels like it's a simple thing, though.
Yeah. You're human, right? We all are.
Yeah, I know, but some people don't make mistakes that are that simple,
Yeah.
I don't think you would have done that, I think you would have probably caught it.
I think any of us can make those errors. It happens. You look at a slide, you deal with the situation, and you move on, right? Because there's another patient, there's something else to do. There's always pressing pressure.
So we're so busy in there, and I just feel like, I just feel pressure. Just keep going, keep moving. I just feel like you think you're doing your job properly. Maybe you're not. I don't know.
Yeah. You're not alone in feeling that. That's for sure.
Now I've got all these people, I'm hearing people say, oh, maybe you should have done this, should have done that. People yapping away. It's just, I don't like that. I just feel like I don't know.
Yeah. But none of them were there, right?
Exactly.
Yeah.
That's what's so easy to talk about things like after the fact.
Hindsight's always 20/20, right? Yeah. You gonna take any time off?
I don't know.
Might be nice.
I know, but I should probably just get through it, get to the next thing.
Yeah. Have you talked to anybody kind of outside of our hospital, of our department?
I mean, yeah, I just don't have many people that can understand it, you know. They can talk to people, but it doesn't mean you're sort of connecting with someone, you know.
Yeah. I have a colleague that went through something similar and went to see this person. She kind of specializes in this, and nice to just have somebody who can understand but be separate to talk from.
What do you mean, like what? Like
A therapist who kind of specializes in professionals, someone who's on our level, who's had to cope with these tough things.
I mean, do you think that's what I need?
It's worth a shot. Happy to cover a few shifts for you so you can get out of here and talk to somebody, get away, clear your head, sleep.
Yeah.
I'm sure we can get things covered.
Yeah.
When's your next shift?
Tomorrow.
I'm free tomorrow. How about I cover tomorrow? At the very least, it's a day. It's one step.
Yeah, maybe, I don't know. Just want this all to just go away, you know, I mean, just completely. I wish it would just sort of disappear. And
Yeah, that'd be nice.
All right, let's stop right there.
Wow.
Yeah, let's give it a round of applause. Oh, no, Rachel, you stay,
Oh,
you
no,
stay.
Don't go away.
Everyone wants to run. You
It's
did
always
great.
good to see a natural, Bruce.
Yeah, you did
That's
great,
beautiful.
Rachel.
Thanks.
So can you tell us what you and your colleagues were talking about as you prepared?
Well, I don't know. We talked a lot about it being natural and just asking questions, letting them talk. And
You wanted the comforting to be natural, the interaction to be natural.
Yeah.
That's easier said than done. It's easy to be natural if it comes naturally. So,
Right.
what did that even mean to you? What was the goal of it being natural?
well, I thought it would be most awkward because this isn't real, right? so
Once you were in it, did it feel real?
yeah,
Yeah,
it
does
did.
feel
It
real,
really
right?
did.
Yeah.
It felt a lot. It felt real.
Yeah.
In obstetrics, sometimes we have things go wrong.
Yes.
And so this isn't the first time that I am the division director for the general OBGYNs and then work in our risk management department. So it's not the first time that somebody's had to cope with this stuff. So we
Yes.
actually do have a therapist that we send people to.
I see.
And it's been great to get outside
I see.
of our department.
So can you tell us anything about, did you have a sense of using particular techniques or tactics, or was it all just, this is your natural comforting style?
Well, I tried to adopt some of the things that you had talked about.
Such as, I thought I heard them, but I didn't know whether you did them intuitively or did them, as learning.
Repeating
Yeah.
and identifying
Yeah.
kind of the emotions and not talking about what I would do or how I would feel.
Yeah.
Although sometimes I feel like that's a little natural to.
I think so too. I think that advice I'm a tiny bit uncomfortable with because we've seen it work sometimes. It's like, it's just a fine line of if it turns into a discussion about you
Right,
and a long
right.
discussion of your experience, then I think it takes away. But if you're wanting to identify, if the main purpose of relating your own experience is to identify with them and say we're more similar than you think, because it's very isolated in this feeling.
Right, and I think it's good to say, look, I could have made this mistake. Anybody could have made the mistake. They weren't there.
Yeah, I wish I had taken notes on all the little things you said that you did well, but Tim and I both noted that you volunteered to take tomorrow's shift, which I thought that's showing solidarity. We talk about showing solidarity. You know, we once had someone come up from the audience, and they were doing a nursing scenario, and the nurse had made an error, and the actress playing the nurse was saying, "I'm going to get fired. I know I'm going to get fired. I'm going to get fired." And the guy was like chewing gum, laying back. "You're not going to get fired." And there was like, you can't promise that. And he said, "Well, I'll tell you what, if they fire you, I'm quitting too. And that was solidarity. So, and you're the same thing with what about tomorrow? I'm working tomorrow. I'm free tomorrow. I could take tomorrow's shift. I thought that was great. There's a few other things I thought you did really well, and would you offer a self-evaluation of your performance?
I mean, I think it felt okay.
Okay.
It's always hard to know what the silences are. If the silence and what the person's thinking, if they're thinking, you don't know me.
Right.
Quit trying to pretend that you do. That was my biggest fear, was
Yeah.
that not really knowing the person. Because in my situation, I would know the person, and I would know their family, and I would know what we were dealing with and how I could help. But
I mean, in a big hospital, though, not all of you work in big hospitals, I realize, but a big hospital, that's not possible.
Right.
You can't always send in a peer supporter who knows the person very
Right.
well. It's going to be almost a stranger, just a distant colleague or something like that. So that's interesting that voice was in your head. Any other self-appraisal of how you did, or other opportunities to do things any differently? I mean, you did really well. I don't see dramatic opportunities for you to do things differently, I'll put it that way.
I think every situation is so different, and really reading the person is the hardest part.
Yeah.
And then trying to figure out from that cue, where do I go?
Yeah. If there was one thing I thought you had opportunities to do, I thought there were opportunities to just make more observations of his affect, of his demeanor.
Yeah.
Because he was so sad, he was so quiet, he was so withdrawn.
Yeah.
I thought there was an opportunity just to observe that and see whether there was, you never know how he's going to play it and whether that's going to pay off or not. But I thought there was
It won't pay off,
You seem
Bruce.
really,
It never pays off.
whether there's an opportunity to just make, often I think one of the best things to do in empathy, especially when someone's withdrawn, is just make observations about their behavior. I don't know how you're feeling, but you seem really withdrawn. You seem so much more quiet and distant.
Yeah.
And then see if that gets you anywhere.
if that would open a door.
Yeah.
Because it
And-
was a lot of quiet. Like I didn't quite know how to
to
get him to say
penetrate it.
more.
And I think
Yeah.
when that happens, observation of their demeanor and affect is an effect, even just their nonverbal behavior.
Yeah.
Andy, what was it like for you?
I mean, I don't know if it came across this way, but I thought that was so excellent.
Yeah.
Honestly, I just thought you were just so natural.
Why didn't you cheer up then?
Well, I was going to say,
It's not about fixing it, Bruce.
Yeah, I didn't change how he felt.
Yeah, exactly.
because I don't just being in this position, I don't see that the goal can be to go from being withdrawn to sort of be cheerful.
You're absolutely right.
I think I'll still end withdrawn, but that doesn't mean we didn't connect in a really human way. And I think and that's what I thought was so good. You managed to. I think there was. I don't know if it was conscious, but it seemed to sort of mirror my tone, and we kind of had a really good balance of just talking and silence and talking, and it was just a very natural conversation, and like began where you just came out and just said, "You're a great doc," and then you left it there and let that hang for a little bit, and then you said something else, and you just dropped these little things in there that just landed, and I just felt it was just really effective for me personally. I don't know if it came across.
I agree. I think your manner, you were very natural. It was very natural. I thought that was one of the strongest aspects of it. Anything else to add, Andy?
Yeah, just great work.
Okay, so let's, Tim, did you have anything to add before we open up to the audience?
No, I mean, I agree. Part of saying you're a great doc is hitting that one thing people fundamentally want is they're still a trusted member of the team. Just by saying that probably made you feel that way. Just that one line. That was, I agree. I perked up when you said that. I said, wow, that's really perfectly timed and well said.
Great way to start.
Yep.
And we might think that they already know, or simply saying it can't make it so, but it's nice to hear. Even if he's telling himself, I'm terrible, I've done a terrible thing, boy, it's nice to hear one of your colleagues say it.
Yep.
It's something to hang your hat on. So let's open it up to your colleagues and see what they thought. What did you guys observe in this interaction? Yes, please.
Okay, so I'm totally spoiled because Rachel's mine, so I get her.
How lucky you are.
Wait a minute. What do you mean she's yours?
Right. Well, we work together, but I get to use her. But two things I thought were like fantastic. One, at the beginning she said, "How you sleeping?"
Yeah.
And like that was her way of saying, "I know you're not sleeping because
Yeah.
I've been through this."
Yeah.
But she didn't make it about herself. But I thought the way that she said it was like, I know you're not sleeping because I've been there. And so I thought that was like fantastic. And then second, she, we talk about, we don't want to fix the problems.
Yes.
We don't, but what she said is, well, when's your next shift? So like as the way to kind of what we talk about in the patient conversations, which is what's the next thing? We're now going to get a CT, we're going to follow up, whatever. Mm-hmm. She did that here, which is the next thing for you is you have a shift tomorrow. Okay, let me pull you out of that. And so that was kind of her way of saying like, because if she says, what can I do to help? Well, when you're in crisis, you don't know.
Yeah.
Like a death of a family, people say, what can I do?
Yeah.
I don't know.
Right.
But she said, tomorrow, what do you have tomorrow? Let me take care of that. And I thought it was just fantastic.
And there's a big distinction, I think, between fixing the emotion and fixing something else. Like, there's one thing we want to give you permission to fix, and that's protecting patients and making sure the next patient is safe. This is one of your responsibilities when doing care for the caregiver. It's not ultimately your responsibility to pull someone off the line. You may not have that authority when you're doing care for the caregiver. But lurking in the background, you have to make some evaluation at some level of their fitness to take care of the next patient. And you didn't have to probe that deep. You were just trying to help them. But I think that's different than trying to fix the underlying emotion. So that's why I think it worked so well. And it has the implication of, I care for you, I want to relieve your burden, and so on. Other thoughts and comments from your colleagues?
We
Go
actually
ahead.
do, if we have a really bad, unexpected outcome, even if the patient survives and it's not a death, but it's something that's really unexpected, we try to pull people because we're in such a high intensity specialty that we try to relieve the whole team.
And you
so
have sufficient staff to be able to make that happen?
It's hard.
Yeah.
We had this happen on New Year's Day this
boy.
year, and New Year's Eve, and I worked New Year's Eve this year because we had the exact same, like, just completely unexpected, and the team could have gone on, but they
needed to be
relieved, and so we took everybody out.
So could I ask, how many other organizations have areas where you actually use that approach? Because that's unique. It's really good to hear. One of the places that's experimenting, a really great place, Virginia Mason, they do a lot of really great stuff. They've created a process called the auto pause. So in some circumstances, all the resources, they try to figure out how can they get them to pull the person off. Mm-hmm. And they're beginning to experiment with it because of what Bruce said about the fact that they may not be safe, to go in and take care of the next patient. And it's the new best practice of how to support your colleagues, but also patients at the same time. It's so lovely that you guys have really built that.
So it's 3 p.m. We want to get the next case done by 3:30. Let's give Rachel a big round of applause, and Andy as well. I'm going to, Tim, do you want me to go ahead
Well,
and
just
set
set it
the next
up
case?
real
Okay,
quickly.
very good.
So the next case, you're all too, we'll do the slides now, you're all too familiar with. It's actually the case that involves the nurse who gave the 10-fold overdose and almost killed that patient. And now we want you to huddle up again and think about, this is going to be very different. So you're going to want to be very observant of what's happening in this case of, now you need to provide peer support to this nurse who knows that there was this huge overdose. And you saw how angry the patient was in the video as well related to that. So again, this is a private room that just like the last one, it's likely though going to be a nurse who's providing peer support in a private room not long after the event has happened. Maybe 2 or 3 days or what have you.
And we should say one more thing, which is that we can assume that the person being comforted knows that this peer support program exists. It's not just coming out of the blue. You might say, this is all part of that peer support program, and they're going to know what you're talking about.
Right. Okay. So huddle up for a few minutes, and then we'll do the...
I'll give you a briefer huddle, no more than 10-minute huddle here, and then we'll get started so we can finish by 3:30.
What does Dr. Green give you? What's going to happen with Dr. Green? He's the one that nobody can beat him. I've never been.
So I assume we're the best.
What I would like to know is say now, I know hopefully I'd be able to tell her that. Like I said, it kind of depends what hat I
All right, folks. So just a clarification, when I said
Right.
wrap up at
The other-
3:30, I just meant this section. We'll adjourn our whole day at 4 p.m., but Tim has a few more things to say, and then we want to go around the room again to get some closing comments. So if we could black out the screen, that would be great. We need a volunteer, a nurse to comfort their fellow nurse. We know there's no shortage of nurses in the room now, so we got to get a volunteer. Who would like to do an active service for their colleagues? That's what this is. You're not just volunteering, you're doing an active service for your colleagues. There's so many good nurses that had good thoughts. I can see you now. You're about to get up from your chair. Come on now, don't make me pick you. Shall I beg? Please, can we please have a volunteer? I hear a volunteer. This table is bursting. Who from this table is going to come? You're putting on lip balm. That's what you do right before you volunteer. You're not? Okay, you don't want to do it. How about you, Sarah? I saw you moving. Okay. Yes, thank you. Thank you, Amanda. You do your best and we're going to learn. The point is not to be perfect. Is you're doing this active service for your colleagues and you'll do your best and then we'll all learn together, okay? All right. So can you tell us what you do in real life, Amanda? Let's get you a microphone first of all. Can you tell us what you do in real life?
I am currently the Director of Inpatient Services and the Chief Nursing Officer.
Okay, so, and who will you portray in this interaction?
Well, we discussed this a little bit at our table. That's kind of hard. Mm-hmm. It feels like maybe peer support should really be from a peer. And
Like another staff nurse or the nurse manager from that unit or what?
We thought even maybe like the house supervisor.
I see.
Somebody who maybe has a little more seniority or experience.
Uh-huh.
Just a little more perspective, but
Not her direct supervisor.
and maybe not somebody who has the authority to issue discipline
Yeah.
necessarily.
Okay, so let's assume that's who you are. How's that?
Okay.
All right.
What's the patient?
And the nurse's name is?
Nurse's name.
Sarah. So whenever you're ready, Amanda, please begin.
Hey, Sarah.
Hi.
Hey, how's it going?
Okay.
Going okay?
Yeah.
So how are you feeling? I know some stuff went on with the patient earlier today, and that can affect us. How do you feel?
I don't know. It's bad. And how would you feel?
It would be tough. It would be tough. I think.
I mean, I'm lucky. She's okay, but.
Well, I think you should give yourself credit in that. Lucky, maybe underestimating your own abilities. You recognized your error very quickly and made the assessment to turn the patient around. Mm-hmm. So recognize maybe your strength in that. I agree that it's a tough situation to be in. It definitely is.
Yeah.
How are you feeling about going forward in this shift?
It's terrible.
Terrible?
Yeah. Just, I don't know. I'm like afraid to do things, you know. I'm just terrified making another mistake. And I'm sure everybody's looking at me like, oh, she's probably pick it up again, you know.
I can understand how you would maybe feel that way.
Position, of course, gets off, you know, because I feel like everyone's looking at me like blaming me, and I didn't mean to, and I'm just like, it's not fair. It's like, this is not fair.
Yeah, I hear you saying it was a process, you know. It wasn't just you, and there was a lot going on there. You had a lot to work through. Is there anything that we can do as a team to make you feel better?
Mm-mm.
No. Mm-mm. You know,
Gosh, I feel horrible. I feel so bad.
Yeah. I can understand these situations are tough for everybody.
I feel really alone.
It's okay. It's all right. It's okay to feel alone and just know that we're all here.
Mm-hmm.
And today was just a moment.
Mm-hmm.
Not necessarily the measure of you as a nurse.
I don't know.
You've done some really great things.
I should maybe just retire now.
That would be a loss for the organization. You're a great nurse.
I don't know. You're so nice. That's nice.
Well, we value you and you've done great things for us.
Mm-hmm.
Do you feel like you need to step away for a while? Would you feel better if you...
Is that what people are saying?
No, they're not saying that. I just want to make sure that you feel okay going forward. And if you need to step away even for, just 30 minutes or however you can come back and feel okay and confident in your skills again.
All right, let's stop right there. Thank you, Amanda. Let's give her a big round of applause. And Marika, too. So, Miranda, what did you and your colleagues at your table discuss as you prepared to have this conversation?
We talked about the fact that ultimately the goal, we all have encountered situations in which nurses experience something like this and really the rest of their career was at risk. They had said, I don't ever want to go back to the bedside again.
Yeah.
So...
Not because of what other people were doing to them, but because of this self-perception.
Yes.
Yeah.
Yeah.
And what did you do in those situations?
So again, we kind of talked about what happened in that moment. Sometimes it was out of their control,
Yeah.
but it didn't necessarily change that the outcome was a poor outcome.
Yeah.
And that their entire career can't be reflected in that one moment or however the situation unfolded doesn't provide the whole picture of their ability to positively impact.
Yeah, and I heard you saying things to reflect that in the interaction. What did you expect to see in terms of the emotional reactions, and how did you plan to deal with them?
Honestly, listening, I think, is the best way to get through those. And I knew that when it happened in the last scenario, when she said, can I take your next shift for you? I thought to myself, that could be perceived two different ways, like, oh, thanks.
Yeah.
And also, like she responded,
Yeah.
is that what everybody wants?
Yeah,
Are they
yeah,
scared
yeah.
of me being there?
Right.
So that's
I'm not doing this to help you. I'm doing this to protect patients.
exactly. So that's kind of a scary or risky place to go. And I'm not sure you can, I guess I would need help reframing that in a way that couldn't be perceived that way.
Yeah. Yeah. Reflecting on how you came up and said, I'm going to be terrible at this. I think that was your anxiety talking probably. But how did you think you performed in the actual event?
Okay. I mean, not fabulous.
And why do you give yourself a not fabulous evaluation?
Well, I guess because I feel pressure to move the conversation. But
that's interesting. Say a little bit more about that.
I think it's my nature, and maybe just all of our natures, to move a conversation.
Yeah.
But it's not necessarily a conversation that needs.
Yeah. I love this because I think it is not the right impulse in this situation. I understand the underlying, especially all of you nurses, there's work to be done. There's another patient who needs me. You are trying to take care of people, but you are actively trying to there's a bias to action. I love this idea of moving the conversation along. But I think in these empathy situations, it's exactly the opposite. I want to stay here instead of move things along. I want to stay here as much as possible. But may go against your impulse. And maybe when you came up and said, I'm not going to do a good job, maybe you sensed your impulse was going to be to try to move things along instead of to stay there. So she was emoting a lot, right? She was very sad. She was very, and there was a lot of opportunity to be in it with her. And that's the advice that I would give you is just try to overcome this impulse to do something. You already recognize it in yourself, so you're halfway there. And so realize that your opportunity when trying to offer empathy is to stay still and be there with her. And so many observations just to observe her when she was being so quiet and withdrawn. And to see if in observing her, this would invite her out a little bit and there might be more. And wallow in it with her. I think this is against our impulses, but I think what really works is get right in there with her and wallow in it. It's terrible. It's so sad. You feel so awful. And check your perceptions. Are you right? And at some point you might exaggerate what she's feeling and she'll correct you. But I think that's what I was feeling. Does that make any sense?
Yeah, absolutely. I think that's probably even more so than some nurses, my personal tendency to move.
And that's probably how you rose to a position of leadership. So it's ironic that certain of the skills that get us into leadership positions are not exactly all the skills we need once we're in leadership positions, when these empathic skills have become really important as well. So I think it's an opportunity for continued growth.
Yes.
Marika, what was it like for you?
Yeah, I mean, I think give yourself credit. It's an incredibly difficult scenario to deal with, and I did see you trying to take that time, and I appreciated that. I think you did leave room. I could know that you had that impulse to keep it going. I thought there were some really nice moments of well, that's not what I'm hearing. That's not what I'm seeing. These sort of things that I was coming up with in my head, saying, well, that's just. I don't see that. I don't think that's true. And just letting that live there. One thing I would say maybe just a little that I would have appreciated is maybe there was a lot of sort of technical, well, it's fixed now, everything's okay. Instead of maybe more focus on how are you actually coping with it? how are you feeling right now? You seem really, naming the emotions, like you seem really sad. Is there anything I can say or help you with or do? Maybe more of that offering of something active, I think.
Yeah. What can I do? That's one thing that you didn't ask. What can I do? I think this is always a safe and useful question. What can I do to help? You know, I'm here from the Care for the Caregiver team. I'm here to check on you. And like the most important thing for me to find out is how you're doing in the first place, which you asked right off the bat. And then what can I do to help? I'm not sure what you need, but I really want to offer whatever I can. If there's something I can offer, I want to give it. There may be things you need or want which I can't give, but if there's something in my power to give, I want to give it. But you have to check what that is. Go ahead.
As I was observing earlier, I thought, how do you end a conversation like that? That's a hard conversation to end. And as Rachel was role-playing here, I thought, you know, maybe you say, let's go for a walk. And then that walk or something can take a conversation in a completely different, you know, direction.
That's interesting.
Maybe you talk about the birds. I don't
what
know.
we found, there's Christiana Care has developed the most extensive and frequently used Care for the Caregiver program that we know of, and they did a bunch of statistics on their thing. And Tim, do you remember? Is it half an hour on average? Is all these things take?
The beautiful thing about their data shows, if you hardwire this and you do it, it's not a huge ask of people in the organization. So they have, I think, 20 people on their team who volunteer to do this. No more than 3 times a year does each one do it. The average time is 30 minutes. They also have a little card, like we were talking about the card of the questions to ask, a little card of prompts to remember is part of this conversation. And one of the final ones is, you know, I just want to make sure you know I'm here for you if you need it. Here is my card. And you may not even be comfortable talking about it right now, but you might be later. So here's my card. Here's my phone number. I'm going to check in with you again because, you know, that's our program. That's what we do. But in the meantime, if you need my number, here it is.
Yeah.
And then, is there anything else I can do for you right now? Okay. And so this is literally built on the card of the things you can say to break the ice, to remind yourself one of the things that you do to do that. And that's really helped. Just look at it right before you go in as a prompt.
And there's one other question which I think is just universal, which is what else? Mm-hmm. What else? And then when they finally say, I got nothing else, you say, okay, let's wrap it up then. But I wanted to make sure there wasn't anything else. I remember once being interviewed by, I went to my internal medicine doctor years ago, and I had some, vague neck pain or something like that, and she had taken care of me, and she kept talking and talking and talking, and finally I was like, I got nothing else, Doc. What are we still sitting here for? And she just said to me, okay, I was just waiting for you to tell me there's nothing else. And that was the end of the interaction. So let's open up the audience very briefly for a couple of questions or observations. So tell us what you were thinking when you watched Amanda. Yes, please.
Well, this is just a question more than anything, and we haven't really talked about it today, but the use of reaching out or touching or in some way making a physical gesture, because there were several points where I wanted to frankly give you a hug because I could see how much pain you were in. And is it appropriate, and how does one use that? And
right, great question. Yep. We love the idea of touch, but it's fraught, right, with peril. So are you a nurse? So in real life, when did you touch your patients? When, other than physically caring for them, when you were comforting them, when would you, under what circumstances?
This expression of when you look grieved or distraught or uncomfortable.
Would you ask their permission before touching them, or would you just simply touch them?
You know what? It would depend on the vibe I've gotten. But in a situation where I might have some relationship with that person already, I probably wouldn't even ask for permission. I would gently...
We feel like sort of in the post-Me Too era, the advice we have to give is that you kind of have to ask for people's consent. It was interesting in California, we were talking about this exact issue, and I said, I think touch is incredibly therapeutic and powerful, and I encourage you to do it if you can get people's consent. And one woman shot up her hand and said, don't touch me. I don't want to be touched.
Yep. Well, and I worked in the Middle East for 3 years and repatriated in 2016, and you had people from 63 countries there. You really had to know what were the cultural boundaries and the other stuff doing that. So as Bruce says, it's fraught with peril. But boy, if it's okay with the person, it can be the most powerful thing you do. And sometimes the only thing you need to do.
Yeah.
So it is, but I agree, in these days, it is fraught with peril.
It is.
Oh, yeah.
And I think that you
really
can ask people. I think there are kind and gentle and ordinary ways of just telling someone, I really just want to reach out and touch you or give you a hug? And would that be okay? And remember, in this case, it's your colleague, which in some ways makes it more fraught with peril. But if they give you permission, you can just go ahead and do it. Mm-hmm. We've seen spontaneous, in role plays, we've often seen nurses mostly spontaneously go and just touch the person they're comforting.
I almost reached out, but I was like,
we're gonna play it.
Yeah, yes. Yep. So another comment or two before we have to move on. Yes, please.
I just have a question, and I don't know, maybe Rachel could answer this better, but I thought everybody did a good job, but nobody talked about like what was next. Or do you have questions about the process going forward? And you're a physician, so maybe you don't want to know what the process is, but is there an opportunity for the support person to say, you know, we're going to support you through this. There's a process, and we've got a strong team behind us that's going to be with you by your side. Yeah. Neither one of those conversations came up. And the first interaction may not be the place to do that, and neither of the actors asked.
Yeah.
But my question is, especially from physician to physician or nurse to nurse, do you say, you know, this has happened before, there's a process behind it, and we've got a strong team that's going to support you through it?
It's what I said is what happens. The conversation's about done. Is there anything else I can do for you? I'm going to give you my card. I'm going to reach out and see how you're doing. We don't mention team. This is one-on-one. We don't want them thinking there's 9 people running around waiting to catch her. This is not that. If you're thinking about that, that's a whole different kind of this is just peer, and here's where I am, and here's where we're going with it. In Christiana Care's data, only 4% of the time did they need a second visit. That's how powerful it can be if you make this good connection. So, and
this is not litigation support.
No. That's a whole. That's a whole different thing.
They're going to be prepped for depositions, and we're going to help.
Yep.
You know, this is not that. This is a separate thing.
Yep. It's creating what Peter Provost would call that micro moment of positivity resonance. It's like the empathy video. In some ways, this is about love in the platonic way. That's why reaching out, the gentle touch, the being there. That ultimately is your goal. So they know they're cared for, you know, they know they're loved by people in the organization, and they're going to get support. But that's usually just that one conversation enough to go, oh my God, this is great. So I'm not alone.
There's a whole other can of worms, which I don't think we have time to dip into now, but there is a question of what was Marika drinking? Is she fit to take care of the next patient? Did anybody notice anything about her affect or demeanor which was troubling? Did she seem intoxicated maybe? Did anyone draw the inference that she was intoxicated?
How much had you been drinking, Marika?
I'd say at least a few glasses of wine with lunch.
Yep.
With lunch.
A few glasses of wine with lunch today. Yep.
So that's an issue which we need you to be alert to. You guys are all experienced enough to know that substance abuse is an potential issue with any and all of your colleagues at all times anyway. It's an occupational hazard for health professionals. But under these circumstances, the risks that someone is drinking too much or dipping into the benzos or something like that is heightened. Mm-hmm. And you have an obligation to your colleagues and to their patients to be alert to that. It's a longer discussion, maybe 1 or 2 comments about that, Tim. And
when you build we're going to get into operationalizing now and some lessons learned. We won't have time for the video, but let's give it up for these guys.
Let's give Marika a round of applause. Amanda, thank you very much for volunteering.
Amanda, thank you.
Don't look up your coffee yet.
And how many people in here have seen Chicago Fire?
I knew she was.
You didn't know who she was. All right.
She knew.
So Marika is a very prominent actress in a whole lot of TV things. One of the ones she was in one of the was it March 22nd, Marika? Either 15 or she's in the entire sort of session. She plays an abused wife. It's if you get a chance to go back and look at it, it's amazing, and she does an incredible job. So,
yay, Marika.
So these guys keep up their acting skills and all sorts of amazing, and that's why we pick them to do a lot of this really cool stuff. So quickly, we're going to go through some of the operationalizing and then lessons learned. You've seen this diagram before, and the paradigm shift. Part of what I talked about is the go team concept. And for some organizations, it's the best way to begin to hardwire this. Like when aviation happens. When Southwest Airlines had that death, they activated a go team. And it was amazing how many parallels there are to that as when you have a catastrophe in the hospital. So when they do the Go team, which really measures you as an organization about who you are, what you're about, and the rest of it, it is this idea of how are you going to support in what we call the big three. The first is the event review, state-of-the-art event review. Who are the smartest people in the organization who understand human factors in these big cases to figure it out? And then how do you activate a care for the caregiver team as quickly as possible, and then communication with the family like we heard with the Melizzo family. That's the concept of Go Team. And when people operationalize it, it's how do you find those people? How do they go through this kind of training so you have a small number of super communicators who you can pull in and do some of these activities. So one of the things we saw, and I got this from Dr. McCoy, as you know, is the grandfather or whatever of Candor in Iowa, and the amazing guy, the obstetrician who is really part of the legislation. He shared this kind of org chart of how they operationalize it in his organization, where they have an overall team leader or leaders, and then in these domains they have leaders who just build out these lean, mean, ready-to-go teams in care for the caregiver, the communication piece, the event reporting, and the resolution part. So a lot of and there's a ton of resources about how you can go about doing that. We just published a paper. I can share it with Kate again, or I may have already. I don't know if it's in the packet of, we've worked with 200 hospitals already, some as few as 2 beds census, all the way to massive, huge academic institutions like University of California, San Diego, Georgetown, Loyola, and others, of different ways that you can begin to think about operationalizing some of this. The nice thing is, as we do the workshops, as we go forward, we'll share more and more if you're interested in how you can begin building this piece of it. But in general, this is how people see it, because as you know, with high reliability, there's deferring to expertise. There are some people who are amazing at event review. As you heard from Bruce, there are some, as we saw, up here, amazing people at providing peer support. And then as you saw in the video and some of the other pieces here from various people, how to communicate to patients and families. And again, different ways to operationalize and bring that sort of stuff together. And we'll share all of that with you as time goes on in the other workshops. But I thought it would be useful to kind of see, and you don't need a ton of people. At the University of Illinois, I probably only, and we were a huge academic hospital. I think I had probably 12 people on my communication consult team, total, for the whole place. A couple of nurses, one of the chaplains, maybe 4 or 5 really good physicians who could coach others when these bad things happen. And the same with the peer support. I think we probably had maybe 12 to 14 clinical people involved in that. It grew over time as the needs grow over, and that's what happened at Christiana Care. To give you an example of how this can go into place, having this there, we had a horrible thing. One of the things in labor and delivery you hate to have happen, but at 4 o'clock in the morning, we did hand a baby to the wrong mom who breastfed that baby for an hour, turned the lights on, and the whole world knew that shouldn't be her baby for lots of reasons. So how do you deal with that? We were hardwired. Just like we had ready. This was a year or so after Michelle passed away. Hotline went off. Nurse knew, my hair's on fire. There's a number I can call to activate the Go team, because this is a Go team. So her hair goes on fire. She calls 34 RSK, the internal hotline, goes to our safety risk manager on call, gets the call and says, oh God, this is over my pay grade. And went to the CMO and found out the CMO was out of the country. So then it went over to me. And so I get the call. So what do you do when you get that call? You cannot wait. And this goes back to, the issue of the legislation. We actually don't have time. It's 4 a.m. to get the form signed, risk management. It isn't even in-house to be able to, and you've got to have immediate conversations. You got 2 conversations to have. One with the woman who breastfed the wrong baby, the other whose baby was breastfed. And you need a super communicator. And so I called and I said, okay, who's on call for OB? I cried. Do you remember the curve? Bruce's curve? It was over here. She's one of that 5% of doctors who has unique ability to piss off everybody she meets. She goes to Burger King and they're pissed as can be in her to leave. So I'm thinking like, oh, well, okay. Family medicine also delivers babies. So I said, hey, who's on for family medicine? All the way over here. Honest to God, Mark Potter, program director of family medicine. Brilliant communicator. Call him up, no problem. I've had harder things like this to do. Can I have a little bit of benevolent gestures, which is a little money, maybe to provide 2 or 3 months of diapers or something? But I know I'll go into the chart. I'll make sure there's no infectious disease issues. We manage it. We do all that. And then I'll go in and have a conversation. And he did. And it was amazing. When he was done, these families were basically thanking him for the opportunity to engage in this wet nurse process that happens throughout the year with no problems at all. I mean, he really was. He explained, this is how often this happened today in all other parts of the world. And I know there's no infectious disease issues and all this sort of stuff. He was like Glenn, the doc, with the newborns. He's that good. And so there was no publicity. There was no lawsuit. It went really, really well. But that's the value of the GO team, where you find the super communicators, you activate it, and then you begin to look at it. And there's all kinds of human factors things that we will wait for the event review workshop. But that's not the end of the story. The end of the story is why Bruce and I love doing this. Because when I learned what happened a couple years later, I could have died on the way going home from work and realized we paid it forward. So University of Illinois has the largest medical school in the country, 360 students per year. We do the patient safety education for all these students every year, 4-year curriculum. We tell this story, and when we're done, this woman walks up to me and Dave Mayer co-teaching it, and she starts to cry, and she says, you don't know who I am, but I'm the woman whose baby was breastfed at 4 in the morning. And when I felt the empathy of Dr. Potter, I knew when I had my choice of medical schools to go to in the country that I wanted to come here and I want to learn how to do this. Oh God, I could have died. Honest to God, it was truly an amazing and now she's part of the communication consult team 8 years later. So there is this cultural transformation, this paradigm shift that happens, but you need to be intentional, it's comprehensive, it's principled, it's systematic, and we're with you for the next 3 workshops, and we'll share everything we can with you about different ways that you can begin to hardwire this kind of stuff. So what I want to do now is I'll start over here and work our way around just for 2 minutes at your table. Talk amongst yourselves and just quickly write down at your table the pearls or lessons learned, the aha moments that you got out of today. Then we will start at this table. We'll work our way all the way around with just 1 per table to share with you. And then where's Kate? And then I'll let you wrap it up. Kate, is that cool? That's very good. Will that work out? So yeah, just take 2 minutes at your table. Talk about your lessons learned, your aha moments, the things, the phrases, whatever else you had. And then we'll just go around and have 1 person at each table do kind of a shout out. And then Kate or somebody else from your team, if you can write it down, that's always super good to have. Because then we carry that from workshop to workshop.
I can tell you in my department, in my division, I did want to be intimidated or that. But realize that you have to coach, and it's repetition, and it's we have all the information, and you can't just send people out there with right? Because I think way too often something happens and very popular the person who's is the dog, or maybe because it's being right, and they know they're not prepared. They need to be complete communicator. Right, so what if the providers want 4 years later? So it's like it's a nurse. Being a nurse and have preparation. There wasn't a doctor. Yeah. Nobody knew how to deal with it.
Alrighty there. So, as promised, how about you guys? What is your Bruce? You gotta we'll do the microphone piece here. And again, just one spokesperson for table. Kate's got her marker ready, so we'll be able to capture all these, and everybody can take a picture before they go. All right.
I do the.
Okay, lessons learned or pearls or whatever.
Oh, I mean, I think empathy is key and
Okay.
core to all this. Recognizing you might be a professional, but then realizing you're dealing with a patient. So bringing yourself down to being a human being and relating to that patient as a human being or the family as a human being. That's your first start. So that's empathy is intrinsically human.
Awesome.
And then realizing this is a process you have to go through. It's not just saying, I'm sorry, this is what happened and moving on. You really have to include a lot more, anticipate the questions that are going to come up and try to make sure that everybody is satisfied at the end of the visit. So.
Great. Thanks very much. As I didn't say it here, but as I will often say, just because I'm not a believer in just the apology piece, sorry doesn't work alone. And I think that's what we try to continually convey over and over again. If you think you can go and say I'm sorry and everything's going to be fine, it will not go well.
And also, I think you didn't give your normal definition of candor, Tim. Maybe you should say what candor is a
comprehensive, principled, and systematic approach to the prevention and response to patient harm. I mean, it really is. It happens to be a patient safety program that the data shows has a huge liability upside. I mean, that really is, how our view is, how the data view, how everybody.
But I think comprehensive and systematic are important to remember,
Yep.
that it isn't just about these conversations. There's a lot of other machinery and decision-making and infrastructure that supports a candor.
And that's why we love the lawyers who are here, because they're
That's
the
right.
best
And the
with
insurance people,
comprehensive and
too.
systematic stuff.
Who's next?
How about this table?
Thank you, Matt.
Just the biggest takeaway of, the old school mentality and how it's been ingrained for so long, and how, embracing, I think Tom said it, embracing transparency, not embracing guilt. It's a fundamental change, and it's going to take a lot of learned behavior. And it's difficult for a person to remain empathetic, to remain calm, especially if they're being attacked.
Yep.
And that's something that has to be learned, and that's the how important that go team is, because you're going to need those skilled communicators to do it. And then, for me, just here's what I know, here's what I don't know, and here's what I'm going to find out. That's huge.
It's a nice formula.
Yep. Well, because so much is uncertain. And as we talk about, in that first hour or 2 or 3, you really don't know anything. I mean, I don't know how many of you really involved in risk management, but I would always look. The first story is never the story. Never the story. So you want to look at what you got, verify what's there, and then move forward to do that. But we're not comfortable with uncertainty, which is why we practice it over and over and over with that. Yeah.
Ours was the biggest, preparation, making sure you have that huddle and you have the right person speaking to the patient and their family.
Awesome.
And the buy-in from the providers as well.
Yeah.
Awesome.
It's going to
That's
take
great.
time. But you can go back tomorrow and start huddling. I mean, the huddling thing is the thing that you can start doing immediately on lots of other clinical issues, not always just disclosure issues, stuff like that. Who would like to speak here? Dawn, you're being
You've been
voluntold to
voluntold
speak.
once again.
I guess I got elected. My big takeaway, and they both agreed, was the fact of kind of the structure of it, to talk about positives before you talk about the bad thing that happened, reiterate the good before you give the bad, to establish that rapport. It's an advantage.
Yeah. No, and I think establishing rapport is good. What the other place we're going to see this, Kate, is in, we do training around, like I mentioned, cognitive interviewing. How do you get into the tunnel where the person is when it happened, to make sense of it? And the step 1 there, over and over and over, and law enforcement has learned this, develop rapport. You've got to get that rapport right away. So it's important to know who is going to do the interviewing to figure out what it is. So there's trust and rapport in almost all the communication.
Who would like to summarize this table? Thank you very much, Amanda.
We identified that every hour that goes by is another harm.
Yeah.
That's pretty significant in action and inaction.
Yep.
So what does this program have the ability to do, or compound, I suppose?
Yeah. And what the data shows is, as those hours go by, that's where trust starts to erode. And at some point, I mean, Chrissy, wouldn't you agree? It's just broken. I mean, you've talked to enough families and other people doing this, and this is where putting the patient and family in the center and learning from them is really great. And that's why every one of these workshops is going to involve patients and families, and their experiences, sharing and doing that part.
Who would like to? Thank you very much, Leslie.
So we had a lot of the same topics that everyone has already mentioned, but we also took away that silence and conversation is okay, and the use of the super communicator and finding that right person to have those conversations.
Great.
Thank you.
And as hopefully it was driven, there are times when the doc caring for the patient must be there, but to complement them with the super communicator is all of what we want. So the way to get physician buy-in and say, we're not replacing you with risk management or anybody else. We're supporting you. We're complementing you with these other people who are going to support you through this and help with this communication and be there as well doing that. Because we don't recommend trying to replace people who then, feel, hey, it's my patient and I'd like to be there with that part. So thank you.
Well, our table's unanimous takeaway was here's what I know, here's what
awesome.
I don't know. That was our unanimous. But the other one was the realization of the don'ts. Don't do this. I mean, we're nurses. We like to fix.
Yeah.
We like to fix it now. So it's the listening and just letting it naturally takes place.
Yeah.
Great. Bruce, do you remember one time in Arizona, the number one thing that people said is, what they learned was, it's not about the nail.
Yeah.
Like 6 tables. It was a huge group. We had 170 people in the room. At least 6 or 7 of the tables say, I know what I'm taking home. It's not about the nail. Because as I've told Bruce, a lot of what I've learned from him, I can guarantee you helped save my marriage. It really did. Unfortunately for Bruce, he got really engaged in this after.
It's too late for me.
Too late. No, Bruce, you've got another amazing relationship.
It's never too late. It was too late for my first marriage.
That's right. Hey, Bruce, I had 2 too, so that's okay.
Yeah.
My second marriage, it helped.
Well, they say there's this famous book that I love about psychiatry. My ex-wife was a psychiatrist. And
that tells a lot, doesn't it?
But
Poor
there's a
Bruce.
famous book about.
God.
Anybody ever read the book The House of God? It's a very famous book about the internship year. That same guy wrote a book about his residency, and it was called Mount Misery. It's about his psych residency, at this famous psych hospital in Boston, or outside of Boston. And in the first page of the book, he says, psychiatrists specialize in their defects. And I sometimes think that I specialize in my defects. I'm a communication expert only because I've made all of the mistakes I'm telling you not to make and encouraging you not to make them. Who would like to speak on behalf of this table? Cheyenne, thank you.
So we really took away the fact that the program can be different at your facility, really, tailored to your needs, and to get buy-in from the C-suite and the board to be successful. But that each of us here at this table definitely see that it would be different at all of our hospitals. So.
Yeah, we think that the principles are not necessarily different, but the implementation of the principles is going to depend on the local culture. It depends on where you're at, and your hospitals are so different in size and scope and so on.
Well, and who your insurers are. Yeah. So in California, people may not know this, is that California hospitals cannot employ physicians. It's illegal. They cannot. 100% of their physicians must be independent. Now they can have a relationship with a foundation and all that, but so the independent physician piece is huge in California. And so there's very different when you go to implement it, because we do recommend, that's why I love COPIC being here, love them forever because they've been so supportive of this. The other thing COPIC has done, and kudos to them, is part of our goal is to educate the young. And so for the last 10 years, we put on these boot camps for nursing students, medical students, and resident physicians. COPIC has been a huge supporter of it. The educational piece, they fund scholarships. I was just out in California, with Alan Lembitz from COPIC. We had 30 residents and 20 students and medical students and nursing students. And so it's very different when you can bring the MMICs in the world and the COPICs and the others to the table, because it's so critical. And many of them are super supportive of this. So it's just really great to see, like I said, COPIC here. And there may be other insurers here, Kate, I don't want to leave out, but I definitely recognize COPIC because they've been huge supporters of what we've.
So that's all the tables, Tim. We got
awesome. So any other final any other final words or what have you before we turn it over, Kate, to you to talk about it? As we turn it over to Kate, I just want to say, on behalf of Bruce and myself, how much fun it's been today. And you're leaning in and you're opening up and doing that. This is our love. This is our passion. This is what it's great doing. It's great to meet all of you. And I hope we see you at some of the other workshops going on. So thank you very much for being here and being so engaged. We appreciate it.
Thank you. So I'm going to get you out of here at 4, but I do want to make a couple of comments, I guess. So we were really intentional when we designed this as a workshop series, and I gotta say, you guys really did the work today. So I want to give you a special thanks for stepping outside of your comfort zone, for interacting with each other, and all those great things. So give yourselves a round of applause for that. I want to give a special thank you to Chrissy. For coming today and sharing her family's story, and for injecting the patient and the family's voice into today. And of course, Bruce and Tim and the acting team for all their work today. I think, can you guys agree that they're awesome? I do want to wish you safe travels home, and thank you so much for coming. Be sure to drop off your CEU form at the desk. If you didn't receive a parking validation slip, be sure to pick that up as well. Thanks for coming.